Hello, everyone. We are going to continue our discussion by talking about infectious disease with skin manifestation. So, we are going to categorize them into those responsible, by viruses, those caused by bacteria, and the fungal one. So, we are going to be starting with the viral one. And the first family of the viral infection we are looking at is the human herpes virus. And what is peculiar to these viruses is that they have a tendency to form lifelong latent infection, which can become activated later, causing secondary infections. Most of them can be transmitted by physical contact, right? And some of them can be from airborne, or exchange of body fluids like saliva, blood transfusion, and the likes. So, taking them one by one, the first one is the human herpes virus type 1 and the human herpes virus type 2, which are collectively known as the herpes simplex viruses type 1 and 2. So, how do we transmit the human herpes virus type 1? It is usually transmitted via respiratory droplets or via exchange of oral secretions like saliva, right? And what is the primary manifestation of the infection? What do you typically see? You are going to see vesicles. Like, that's the first thing you have to have at the back of your mind for most of the herpes simplex viruses. Vesicles with erythematous base. So I'm going to be showing us some of these vesicles and we can appreciate how they look like. So vesicles with erythematous base, and most of the time, because this is type 1, transmitted by oral secretion, so you tend to find most of the lesions within the mouth, right? You find it within the mouth, and the primary lesion starts as gingival stomatitis. So that is what you are looking for in the question step. Gingival stomatitis, vesicles affecting the anterior aspect of the mouth, the gingiva, the mucosal of the cheek, which is the buccal mucosa, the hard palate, and the lips. So once you see vesicles that becomes ulcerated or becomes erosions at the end of the day, situated within the anterior compartment of the mouth, like the lips, the buccal mucosa, the tongue, the hard palate, the lips, the buccal mucosa, the tongue, the hard palate, the gingiva. Think about gingival stomatitis from human herpes virus type 1. Very important stuff. Now, when this primary infection um, resolves, the virus becomes latent within the trigeminal ganglion of the head, right? And when there is a background immunosuppression or when the person get exposed to maybe a very stressful situation, you can have reactivation of that virus. And by the time it's coming back, the next time, it's not going to come as gingival stomatitis. So it's just going to form, what you call your herpes labialis, in which you are just going to be seeing like vesicles, like ulcers within the anterior aspect of the lip. That is all. So the primary manifestation is quite different from the secondary manifestation. The primary is the gingival stomatitis, while the secondary is the herpes labialis. We are still talking about the human herpes virus type 1. It's very important because you need to be able to distinguish the human herpes type 1 presentation from the Coxsackie virus. The Coxsackie we call hepagina. Human herpes virus type 1 is going to cause gingival stomatitis. And the only difference is that hepangina from Coxsackie is posterior. So there's going to be affectation of the posterior structures. It's going to go as far as the uvula, the soft palate at the back, right? So once you are seeing affectation of the soft palate at the back, you are seeing uvular vesicles. This is likely to be hepagina from Coxsackie. But one thing that is common to both of them is that they both cause fever and they both cause sore throat. But once you are seeing the vesicles concentrating within the uvula, the posterior aspect of the tongue, the posterior aspect of the soft palate, think about hepagina from Coxsackie. What are the other manifestations that can happen from the human herpes virus type 1? So they can also lead to formation of keratoconjunctivitis, right? The baby or the children, the child rather affected by this infection, deepens the mouth, the hands into the mouth, and from there inoculate it into the eyes. Rub the hand on the eyes. They can develop keratoconjunctivitis, in which there's inflammation of the cornea, there's inflammation of the conjunctiva, so leading to eye redness, eye pain, right? Because of the fact that they can introduce their hand into the mouth, they can develop epitic white lobe. Although this is very common in people that work in the healthcare industry, do like oral procedure like dentists, or people that wash dishes because they are exposed to oral secretions. They can develop epitic weak lobe, in which you are just going to be seeing the vesicles with pain, burning sensation, tingling sensation, and the vesicles are going to be concentrated within the fingers near the nail beds. Think about epitic wheat lobe from the human herpes virus type 1. They can also form erythema multiforme, in which you are going to be seeing the targeted lesion. We should not forget the targeted lesion appearance of erythema multiforme. And we have said it that human simplex virus is the commonest cause of the erythema multiforme. What else are we scared of? Um, Human herpes virus type 1 can cause temporal lobe encephalitis. So it can, disseminate into the central nervous system, leading to temporal lobe encephalitis. There's an encephalitis. So that patient is going to present with some cortical symptoms, right? So we expect the patient to have fever, to have headache, and the cortical part, stuff like aphasia, right? Receptive aphasia, because we know that the Wernicke area is concentrated within the temporal lobe. So Wernicke aphasia, receptive aphasia, they cannot comprehend your language. They can speak fluently, but they cannot comprehend your language. So by the time they are speaking, their words is is um is they are saying the words well, the pronunciation is good, but it doesn't make any sense. It lacks meaning because they cannot comprehend what they are saying. Temporal lobe encephalitis. They can have neuropsychiatric manifestations, behavioral problems, right? Seizures. So a patient that develops fever, sore throat, you can see the vesicles within the mouth, then subsequently progress to develop aphasia, develops headache, seizures. Think about temporal lobe encephalitis. That is going to affect the management, right? And they can develop, other stuff which we have mentioned. So, what about the human herpes virus type 2? So, this one is commonly transmitted by sexual contact or by perinatal transmission from the mother to child, across the placenta, or exposed to when the baby is exposed to vaginal fluid. So, um, what do we see? They typically have genital lesions. So we are going to be seeing the vesicles with erythematous base concentrated within the genital regions, right? And in addition to this, it can cause viral meningitis. So as the type 1 is causing viral encephalitis, your type 2 is causing viral meningitis. How do you make your diagnosis? Straight up, straightforward. All the diagnosis for majority of these viral infection is clinical, but sometimes you might need to confirm, and you do your lab. You just scrape off the vesicles, send it for lab studies, and you can do your culture or your PCR analysis. Your PCR analysis, you are trying to amplify the DNA, and you are checking if it's in keeping with what you expect for the, human herpes virus type 1 or type 2. So that is that. How do you treat? Most of the time you treat with your VAF, your valacyclovir, your acyclovir, or your famciclovir, right? But the treatment options can change depending on the situation. If that individual is having a very severe infection due to background immunosuppression, you give intravenous acyclovir. Intravenous acyclovir is indicated. Or if the person has central nervous system infection like viral meningitis, like temporal lobe encephalitis, that is an indication for IV acyclovir. So moving on to the third one, which is human herpes virus type 3. That's the varicella zoster virus. So it is majorly transmitted through the airborne route, right? And you have two spectrum of infection: chickenpox, which is a primary infection, and when the chickenpox becomes latent and becomes activated later, it becomes shingles. So I want to see if we have some lesions. So this is our herpes labialis or the cold sore, right? And this can be the vesicles and the erosions that you expect, in somebody with gingival stomatitis. You can see the numerous vesicles that has even ruptured, and they have they led to erosions involving the lips. You can see them involving the tongue, right? If you tell this person to open the mouth properly now, you'll be able to see some of them hanging around the buccal mucosa. You check the roof of the mouth, you see some of them involving the hard palate, gingival stomatitis. When it becomes secondarily activated, you just see like most of the time just single lesions, in the anterior aspect of the lip, which is the herpes labialis. Okay, so um, that is that. Um, so for the varicella zoster, so the chickenpox is a primary infection, and what do you expect? Now, the classic presentation for chickenpox is that you are going to see that the patient might have some prodrome, right? Like fever, malaise, you know, just feeling fatigued and tired, right? And subsequently, within 24 hours, the lesions start appearing. That is chickenpox. The lesions, they start appearing, and they start from the trunk. But one thing that quickly gives out chickenpox is that you notice that you have like the evolution of the rash, and it kind of involve all the possible rash that can exist. They will start from macule, from purple, and from there evolve into vesicles, into pustules that becomes, bullae, and they can even rupture. They can crust with eventual resolution within like 2 to 4 weeks. So, um, what is characteristic of the chickenpox is what I've said, but most of the time, what you usually experience the most is the presence of the pleuritic vesicles, with the centrifugal distribution. So it's going to start from the trunk, and they are going to move outwards to involve the extremities, the head, the neck, and the extremity. So that is centrifugal distribution. It can lead to some serious complications, particularly in people with immunosuppressed state. So they can develop pneumonia, they can develop hepatitis, they can develop encephalitis, right? Um, and if the individual is immunocompetent, it can just, suppress and become latent within the ganglion. So I forgot to mention that the human herpes virus type 1 becomes latent within the trigeminal ganglion, while the human herpes virus type 2 becomes latent in the sacral ganglion. So the human herpes type 1 primarily forms a gingival stomatitis, and when it becomes reactivated, it leads to formation of herpes labialis or the cold sore. While for the type 2, they have genital infection, and by the time it becomes reactivated later, they will start developing recurrent genital infection. So for chickenpox, primary infection start as a prodromal phase, fever, headache, malaise, and subsequently after 24 hours, you see the evolution of the rash, starting as maculopapular rash, evolving into vesicles, which are very pleuritic. They progress to, forming papules, pustules, bullae that will rupture, they will crust, and they will heal, and the virus will go down into the ganglion. They can go to the dorsal root ganglion, and they can hide within those ganglion and stay there until there's background immunosuppression or stress that can lead to reactivation. So when there is reactivation of the virus, what do you expect? The individual is going to present with shingles, right? And they are going to have vesicular rash, which is very, very painful. But one thing to always look out for is that you will notice that the area where the rash develops initially becomes very painful. They experience some burning sensations there. They experience some tingling sensation there. So once you have that, then afterwards, you now have the presence of the rash, having a dermatomal distribution, affecting a particular dermatome, a particular segment of the body. Think about shingles. Think about shingles. Think about zostal infection. Think about zostal infection. So this is an image. Let me see what I have here. Um, okay, this is something else which I'm going to show us later. um I thought I got an image for this. So okay, this is an image for the herpes zoster. So we can see the dermatomal involvement. We can see the vesicles just concentrated within the lower thoracic segment, right? So that's what you expect for the zoster infection. So um how do you make your diagnosis? Clinical, right? Clinical diagnosis. Most of the time, you don't do any further diagnosis, but sometimes you might, take, swab and send it your PCR analysis for your definitive diagnosis, or you just do your culture. Any one of that you want to do, you can do it, depending on if there's complication or not. So if there's meningitis, there's encephalitis, you can take your CSF sample and send it for PCR analysis. If there's pneumonia, you can take a bronchoalveolar lavage. You can take a bronchoalveolar washing or lavage of the respiratory tract, and you can, send that for studies. You can do your PCR to isolate the organism, right? So, but most of the time, don't worry yourself about all this. Just know that most of the time, the lesion is what? Clinical. So, um, so for people that are hospitalized or people with disseminated zoster infection, you want to ensure you are isolating them so that they don't transmit that to other people. And you want to ensure proper airborne precautions. So you want to wear your mask, your um, your marks that can ensure. I've forgotten, is it N20 marks or so that can limit, the release of airborne droplets during breathing or when talking or like the like, so that you don't, you know, um, you know, you limit the transmission of the infection. So anybody with this infection, we want to isolate them so that they don't get contact with people that are not, you know, um, infected with the infection. So how do you treat? So most of the time, you want to give your antiviral agents. So just like we have our VAF, you want to give your VAF usually within 72 hours of the viral onset. Because if you give it within this time, it can limit the severity of the illness, it limits the severity of symptoms, it limits viral shedding, and it, you know, reduce the duration of the pain, right? Because it's very painful. So they are very painful and they are puritic. So give your valve to limit the severity of the clinical presentations. And if it's very severe, you're having, encephalitis, you're having pneumonia that is very bad, you must give intravenous acyclovir. So most of the time when the patient is having your secondary infection, secondary complication like encephalitis, you might need to rule out. That's when you start doing your other studies, like do your CSF analysis, do your bronchoalveolar lavage, to be able to know what is going on. Because by the time you start bombarding the individual with antibiotics like ceftriaxone, thinking it's meningitis from bacterial infection, it's not going to work. So that is when you need to do more studies. And if you eventually find out that you are having meningitis, or encephalitis from the varicella, then you need to give your intravenous acyclovir to treat the infection. So you usually have, a live attenuated vaccine to protect individuals, against this infection. So anybody that is immunocompetent, they might receive um, your varicella vaccine, particularly if they are, within 1 to 4 years. So they usually receive the varicella vaccine twice, between age 1 and second, like age 4. And also in people that are more than 60 years, adults more than 60 years, you also give them um, your varicella vaccine. So um, that is that about that, so that you can prevent the primary infection and you can reduce the chance of reactivation. So moving on to the Epstein-Barr virus, that's the human herpes virus, the human herpes virus type 4. So this is known as a kissing disease. So we must know this in and out. Very, very important stuff. How do you transmit it? Usually from respiratory secretions and saliva. So people that kiss a lot, they can exchange saliva and they can easily transmit the infection. And it is the major cause of infectious mononucleosis. And what are you looking out for with respect to infectious mononucleosis? Fever, sore throat, which is exudative, right? Exudative pharyngitis, the fever, the fatigue. So they have this chronic fatigue. And most importantly, the hepatosplenomegaly. So by the time you do your abdominal examination, you notice that the liver is big, the spleen is big, and they can have lymphadenopathy as well. particularly affecting the posterior cervical node. So you get a patient, a young boy between the age of 5 to 15 years, you know, probably the boy has been kissing one other lady, or we got exposed to an individual, with Epstein-Barr infection, particularly through the exchange of respiratory droplets, inhalation of respiratory droplets. So they can develop fever, they can develop exudative sore throat, posterior cervical lymphadenopathy. You do your abdominal findings, there's hepatosphenomegaly. Think about Epstein-Barr, particularly in adolescents between the age of 5 to 15 years. So what are the complications that can affect, an individual with infectious mononucleosis? Just think about the malignancies, both the non-Hodgkin and the Hodgkin lymphoma. So the Hodgkin lymphomas, the non-Hodgkin lymphoma, particularly Burkitt lymphoma. They can have, it's made the major culprit for nasopharyngeal carcinoma. That's very common in Asia. And some post-transplant, lymphoproliferative disease. So people that undergo transplantation that are immunosuppressed now developing some blood cancers affecting the lymphocyte. Think about your Epstein-Barr virus being involved. So it typically affects the B cells, through the CD21. We know this from our step one, causing abnormal proliferation of the B cells. So that's the major cause of some of these malignant problems. And how do you make your diagnosis of your infectious mononucleosis? Diagnosis is usually majorly like you have a very high suspicion from your clinical findings, but you can confirm whatever you are thinking by doing your heterophile antibody test. And essentially, what are you doing here? People with some particular infection, but like Epstein-Barr virus infection, they can produce what you call heterophile antibodies. And these antibodies have the ability to agglutinate sheep or horse red blood cells. So by the time you mix the serum of an individual with Epstein-Barr virus infection with the red blood cells you got it from a sheep or from a horse, if you mix it together, there's going to be agglutination. So that's a monospot test, right? Or you can just do serology, assessing the IgM against the EBV viral capsid antigen. So any one of that, talks about infection from infectious mononucleosis. By the time you do your blood study, your blood smear, you are going to be seeing atypical lymphocyte, which is just abnormally large T lymphocyte, right? Although the major harm of the lymphocyte that is hyperproliferating are the B cells. The B cells are the ones that are hyperproliferating, but you have like a reactive response from your T cells, and they are going to become like large, abnormal, trying to attack to and eliminate those B cells. How do you treat them? Treatment is basically supportive. Like you don't give them any drug. There's no drug to give. Just give them supportive management. They have the abdominal pain. Give them the analgesics. Fluid support and the likes. Basically, that's what you do. So you tell them to avoid contact sports, playing football, playing basketball for at least 4 weeks because of the splenomegaly. So there's a very high chance of the spleen rupturing, and you don't want that to happen. So tell them to abstain from contact sports for at least 4 weeks. And some individual might erroneously think that this is a case of a streptococcal infection, streptococcal infection causing sore throat, and they give them amoxicillin. So that amoxicillin can induce maculopapular rash in some certain percentage of people. So, we have to watch out for that, particularly when it's confused with streptococcus activated pharyngitis. So moving on to the next one, and that's a cytomegalovirus infection. So CMV infection. Um, so so the reason why um we are talking about Epstein-Barr virus as part of the dermatological, agent or the virus that can induce dermatological infection is that sometimes you can have this virus causing maculopapular rash even without giving amoxicillin. So maculopapular rash can still happen with this constellation of signs and symptoms we have described. But if you don't have the maculopapular rash, if you give amoxicillin, thinking is streptococcus pharyngitis, they can also develop the maculopapular rash, but that rash is not related to the Epstein-Barr virus. Yeah. So, What about the human herpes virus type 5, which is a cytomegalovirus? This one can be transmitted through essentially all the body fluids. Think about anything: urine, saliva, blood, organ transplantation. It it can sexually, it can move. It can move across borders, and it causes something very similar to infectious mononucleosis. The fever, the exudative sore throat. They can have the posterior cervical lymphadenopathy. They can have the maculopapular rash. They can have the hepatosplenomegaly, right? But by the time you do your monospot test, it is negative. They don't develop, or they don't produce the heterophile antibodies, right? So that's a way to separate infectious mononucleosis like syndrome from Epstein-Barr virus, from CMV virus, from infectious mononucleosis from Epstein-Barr. So you want to separate infectious mononucleosis like syndrome caused by CMV from infectious mononucleosis caused by Epstein-Barr. So you do your monospot test, which is going to be negative in individual with CMV virus infection. So how do you make your diagnosis? Before that, we also need to know the extra dermatological, presentation of the CMV, and they cause what we call creep. The creep, the creep. So um, the creep is standing for um, the colitis, right? The retinitis, the encephalitis, the esophagitis, and the pneumonia. So we have to know that CMV can cause colitis, right? And the clincher you are just looking for in the question stem is just the linear ulcers, right? The linear ulcers on colonoscopy, if they did it, or the patient is immunosuppressed, definitely your CD4 count in that patient is going to be less than 50. Trust me, it's going to be less than 50. If you do your colonoscopy, you are going to see the linear ulcers, and most importantly, the volume and the nature of the stool. The diarrhea they are going to be presenting is going to be bloody, and it's going to be frequent and small. So you see an individual having frequent small diarrhea, which is bloody, with actual weight loss, and linear ulcers. Think about CMV infection, very straightforward. And of course, there's going to be background immunosuppression. The R is talking about retinitis, and they typically have CMV retinitis with presentation like floaters, visual field problems, blindness, and the likes. And your fundoscopy findings, what is going to help you. We have discussed this in our multi-system compartment, and um, we said that what you typically have is a pizza pie appearance, the pizza pie appearance, in which you are going to be seeing retinal hemorrhages with fluffy areas surrounding those hemorrhagic areas. So you are going to be seeing like whitish opacities, surrounding those vessels, and with the areas of hemorrhage. So that's classic for CMV retinitis. So it can easily lead to retinal detachment. So you have to treat it as soon as possible. Um, the E for the encephalitis, of course, encephalitis can affect the brain, seizures, confusion, personality changes, depending on the area, right? The E, the next E for the esophagitis, right? So they're going to be having problems with swallowing, so odynophagia, and by the time you do endoscopy, you are going to be seeing the linear ulcers at the end of the day. And if you do your biopsy, you are going to notice presence of intranuclear eosinophilic inclusion bodies, as well as intracytoplasmic basophilic inclusion bodies. So intranuclear eosinophilic, eosinophilic inclusion bodies, eosinophilic, and intracytoplasmic basophilic, inclusion bodies. That is peculiar to the CMV infection. And your P for the pneumonia. So how do you make your diagnosis? You can do your biopsy, or you can do your PCR analysis, or whatever sample you are looking at. So don't forget the whole high appearance. The whole high appearance. So that is these inclusion bodies, the intranuclear eosinophilic and the intracytoplasmic basophilic inclusion bodies, which gives the whole high appearance, right? How do you treat? Just give your IV ganciclovir or your oral valganciclovir for your treatment. So IV, the ganciclovir is usually given IV intravenously, Why the VAG ganciclovir is usually given orally. Good. The next one is they are the Roseola virus or the Roseolo virus. So human herpes virus 6 and 7. Many people don't know that the 7 is involved. Please know it now. Know it today. 6 and 7 are matched together as a Roseola virus. And this is very simple. Know that it is transmitted by saliva, just like kissing disease. It is saliva too. Very important stuff. So that's why you usually tell people, don't be kissing babies. Don't be kissing babies. Don't go and be carrying another person's baby and be kissing them. You can transmit Roseola virus, right? And uh, um, how is the manifestation? So what are you looking for in the question stem that will raise your suspicion for this? Number one, that baby is going to be having very high fever more than like 39 degrees Celsius. Very, very high fever that can provoke febrile seizures. So they'll tell you, you know, due to the high fever, later on they notice that the child, start developing seizures. And after the fever subsides, the rash starts. And the rash is just classic like that of the chickenpox. It starts from the trunk too, but it is a maculopapular rash. You don't see vesicles. It doesn't evolve into vesicles or blisters. So you just see fever, high fever, seizures, resolution of fever, then appearance of the rash. So the maculopapular rash appears after like 1 to 3 days, and you see it having a centrifugal spread starting from the trunk to the extremities. It's self-limiting. It is a typical diagnosis. It's a typical clinical diagnosis. You don't need to be doing any laboratory work. The last I have here is so we should know, of course, maculopapular rash, the way they appear, right? Maculopapular rash, right? See, for Roseola, let's see, so that they can show us babies. Yeah, so you can see this guy having like numerous. This is not very clear. I don't have a very clear image here. Yeah, just something like this. We can also check it on our own computer, so you can see that the papules everywhere, and some macles, developing within the trunk, and from there they can evolve into the heart. So, the mere clinical description in the question stem, we'll get it, right? We'll get it. So it's just that we need. We should have that at the back of our mind. That is the most important thing. Yeah. So, human herpes virus type 8, that's a Kaposi sarcoma virus. This one is transmitted by sexual contact, basically. Kaposi sarcoma, sexual contact. Very common in people that are immunosuppressed. Very common in people that have HIV. Very common in people that are, immunosuppressed either from transplant or maybe they have other cause of immunosuppression, maybe from HIV. So you have the one that is associated with HIV classic and the one that's associated with immunosuppressed state from every transplant, right? You have the classic type, and the other type, but we don't need to worry ourselves about the types of Kaposi sarcoma. What the question stem will be testing is just ability to identify the lesion, ability um, to identify the lesion, and ability to make a diagnosis and know the implicating virus. That is what is important to us. And we have said it, we have established the fact that it comes from sexual contact, right? And how does it look like? So you are just looking out for an individual that presents with, purplish, sometimes pinkish, like what we have here is looking like, it's getting dark, you know, um, pink or purplish, or sometimes they can say violations. So, violations, purple, they mean the same thing then. And pink, purples and plaques or nodules. So once you see somebody, most of the time it is plaque because they are very big, they are more than 1 cm. So you see, purple colored violaceous color or volaceous color. I'm not very good with pronunciation. Or pink, plaques and nodules that develops in the skin in an individual with background immunosuppression, either from transplant or from HIV. Think about Kaposi sarcoma. Think about Kaposi sarcoma. And sometimes bacillary angiomatosis can look like this. And what you are going to see in the question stem that is going to raise your suspicion is the fact that by the time you do your biopsy, you are going to see presence of spindle cells. So spindle cells means that this is affectation of endothelial cells. Kaposi sarcoma is a virus that leads to hyperproliferation or a malignant transformation of your endothelial cells of the vessel. So they start hyperproliferating. So and they are normally spindle cells. So see a lot of spindle cells with lymphocytic infiltrate. That is all you need. That is all you need. Spindle cells with lymphocytic infiltrate, Kaposi sarcoma. Spindle cells on biopsy with lymphocytic infiltrate. That is all we need to make our lymphocytic infiltrate on biopsy. Very easy. So you diagnose it by biopsy. Although there may be no gold standard, but your biopsy will help you, right? It will increase your suspicion when you see your spindle cell with the lymphocytic infiltrate. So don't forget, the lesions are um, uh, 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 what's it called? Nodular lesions with plaques, and they appear foliaceous or purple in color or pinkish, and they are not pyretic, they are not painful. So if you get a question saying you have non-painful, non-pyretic, violaceous or pink nodules or plaques in an individual with background immunosuppression, and they did the biopsy, they saw lymphocytic infiltrate surrounding the spindle cells. Think about Kaposi sarcoma. So I think I have like a question here. Let's just see what is here. So a 5-year-old boy is brought to the clinic due to 3 days history of fever. For the past 2 days, he has also had throat pain and has not eaten well. His father is worried because the boy is due to start the fall school term in 2 weeks. The patient has no chronic medical condition and is current with his immunization. He lives with his older sister, brothers, parents, and grandmother, a lot of people. The temperature is 38.23, there's fever, the blood pressure is 108, the pulse is 108, respiration is 18. The oropharynx has several scattered 1 millimeter vesicles, okay, on the anterior palatine pillars. So there's already, an anatomical demarcation, anterior, right? And several gray shallow ulcers are also seen in the soft palate and uvula. Oh, this is changing it because it said the soft palate and the uvula, so that's back, okay? But the tongue, the lips, and the buccal mucosa are spared. Okay. So if the tongue, the lips, and buccal mucosa are spared, so that means it's not actually anterior like I thought initially. So the palate are actually back. The palate are back. They are back, posteriorly situated. It's already affected the uvula and the soft palate, and it's sparing the tongue, the lips, and the buccal mucosa. The skin has no rashes. The remainder of the physical examination is normal. Which of the following is the most likely pathogen I share with this patient condition? So if it doesn't affect the anterior aspect of the mouth, which is the tongue, the lips, and the buccal mucosa, so I'm not going to be thinking about gingival stomatitis. So I have to think about an individual having fever, pharyngitis with posterior structure affectation at the soft palate, the uvula. I think about hep angina, which is going to be caused by Coxsackie virus. Okay. So the way I know, is just to look for the one that is not dotted. So option B is not dotted, so that is definitely the answer for me. So that you guys will know how I figured that out. So C is dotted, D is dotted, E is dotted, B. So B is the correct answer. Okay. So um, we looking at them, one by one again. I'm just dilating a little bit on them. The episimplex generally cause painful recurrent vesicular eruptions of the mucocutaneous surface due to infection of the HSV. Yeah, so we have said that already. They form vesicular lesions within the mucocutaneous surface, like the lips, the tongue, buccal mucosa, the genital areas too. So both serotype can actually affect the genital and the extragenital regions, which is very correct. Your herpes simplex type 1 can affect the the genital area as well as mouth, while your herpes simplex type 2 too can do vice versa. And they usually spread through the epidermal cells. They cause hyperproliferation of these cells and they fuse them together, leading to formation of your Jan cells. So by the time you do what you call your TZAC smear, you are going to see the formation of these multinuclear Jan cells with acantholysis. So there's separation of the epidermal cells in some parts, and we have fusion of some of them, coalescing their nuclei together, giving the appearance of a multinuclear Jan cells. So that is classic for herpes simplex infection. Um, so there's a close differential, which is dermatitis epitiphomi. So this is basically one of those vesiculopulous disease, dermatitis epitiphomi, and what you are going to have here is experience of vesicles and bullae that usually some of them can rupture, leading to formation of erosions. And how do you identify this? You see somebody having vesicle bullae affecting the extensor surface. Think about dermatitis epitiphomis. You don't have HSV affecting the extensor surface, right? So somebody having vesicles and erosions, just like this guy having bullae and some tiny, tiny vesicles, right? Affecting the elbow, the knee, right? The back, the bottom. Think about dermatitis epitiphomis. And what is going to help you further is that they will tell you, you get, something relating to celiac disease, either a form of malabsorption, having steatorrhea, diarrhea, nutritional deficiencies, pointing to celiac disease because dermatitis epitiphomis is very closely shared with celiac disease. So you are going to see symmetric bilateral papules, vesicles, and bullae. Some of these bullae and vesicles ruptures to form erosion, which you typically see at the elbow and the knee. So what you're actually looking at for is the extensor distribution, and of course, in about 15 to 25% are shared with celiac disease. So how do you treat? You treat with dapsone. Dapsone will help them suppress the inflammatory response, and you have to avoid the inflammatory trigger, which is gluten free diet. So you don't tell them to eat anything that has gluten in it. Okay. Um, so we have talked about the presentation generally. The herpes simplex type 1 and 2. Um, you know, the primary infection is due to exposure to oral or genital fluids, right? That's what caused the primary episode, which is going to lead to the gingival stomatitis for type 1 and for type 2, the genital ulcer. And they can become latent in their respective ganglia. The type 1 will become latent in the trigeminal ganglia, while the type 2 will become latent in the sacral ganglia. So it's also important to know that the first episode usually stays longer and is more severe than the recurrences. So the primary infection is badder than the secondary infection. That's what they are trying to say. And sometimes you might get some prodromal manifestations before the lesions start appearing. So you can see like some tingling, burning sensation, and pain in that area, particularly the genital area, before you now see the ulcers, starting to form, like the vesicles forming. So the individual can also have some systemic manifestation like fever, lymphadenopathy, and malaria. So we don't really need all these things; they are just secondary stuffs. Um, so the recurrences are usually limited to the mucocutaneous areas innervated by the involved nerve. So let's say that the the trigeminal nerve is involved, right? It's going to affect the lips, right? Let's say that um the the sacral ganglia is affected, so it's going to affect the pelvis and the perineum, right? So the recurrent, is confined to the area where the ganglion, is situated at heart. So, what is a presentation when there is recurrence of the HSV type 1 causing oral herpes? How does it recur? It leads to formation of the coat sores, which you have explained, right? You just see the crusted vesicles with an erythematous base, and it's usually triggered by stress, you know, by infections, by sunlight exposure, right? So this is an example of the coat sores or the herpes labialis, and it is a manifestation of recurrent herpes infection. We have said that so many times. Please don't forget. Do not forget that. And what is the manifestation of recurrent genital herpes? They just have recurrent genital infection, which is less severe in terms of symptoms and presentation compared to the primary. So you just have some unilateral clusters of ulcers with erythematous base within the genital region. That is all. The diagnosis of the type 1 and 2 is clinical, right? You just see the group vesicles on an erythematous base, right? Either in the lips, the oral mucosa, the buccal mucosa, the palate, or the genital areas. And how do you make the diagnosis? The most accurate one is to do your culture or your PCR analysis. We have talked about that, right? But your PCR analysis and your culture will tell you definitely if it's type 1 or type 2, right? And if you can also do your TZAC smear, which is going to show you the multinuclear giant cells and the acantholytic cells. We have said that, and this is what the TZAC smear is going to look like, so that because some of those we see this in the question stem and we get confused. So these are the multinuclear giant cells, you know. So by the time you look at the history, you will know if it's talking about type 1 or your type 2 infection. So how do you treat? You have talked about diagnosis, that is clinical. You can do lab confirmation. But when it comes to treatment, most of the time, you just, particularly if you are immunocompetent, just give supportive therapy. But sometimes you might need to give acyclovir or your VAV, any one of them, just to speed up the healing process and limit, viral shedding, right? It doesn't cause any harm. You can give it. So if it's small, it's only supportive therapy. But if it's severe or large enough and you feel that okay, you need to speed up that healing, give your valve, any of your cyclovir, your famciclovir, or your acyclovir to speed up the healing and reduce the viral shedding. If they are immunocompromised, you need to give your antiviral drug, especially within 72 hours of the start of the outbreak. So that's when they are most effective to speed up the healing and limit shedding. If you give it outside this time, it's not very effective. I've talked about the hepatic whitlow, right? I talked about the hepatic whitlow as developing the vesicles, within the vascular, the nail beds, right? Just within the tissue of the nail. So let's see if we have something that can help us look at that. So the hepatic whitlow, let me see hepatic whitlow pictures so that we can see what it looks like. I used to have it, but I think I lost it. Yeah, so you can see the vesicles, right? So these are the vesicles. You can see it affecting the fingers. So that's what you see for hepatic whitlow. And most of the time, it's due to viral. It doesn't contain pus. If it's bacterial, you see pus um, involved in the lesion. So they are usually pustular with bacterial, but if it's viral, they are just clear fluids, just blisters within the arm, resembling the dew drops on the road. So very common in health workers, dentists especially, because they do some oral manipulations. From there, they can easily inoculate the virus from the mouth into the fingers, right? People that are working as respiratory therapists, because they also get exposed to the secretion from the mouth, the dentists and the dish washers. So how do you treat an individual with recurrent episode? So just like the same thing, you can treat the minor episode supportively, and you can give any of your valve during the episode to reduce the healing time and reduce viral shedding. So you can see that it's like the same thing, supportive, or you can decide to give your valve just to reduce the shedding time and promote faster healing time. So some people can have severe frequent recurrences. By the time you're having like 6 presentation in a year, more than 6 presentation in a year, you need to place that person on daily prophylaxis with the valve. Like more than 6 outbreaks in a year, 6, that is severely frequent. So give them a cyclovir or valcyclovir or any of them for daily, as daily prophylaxis. So because you don't want you want to limit the outbreaks, so that's why you have to give them prophylaxis with out of the valve. So people with HIV/AIDS can have infection of this episymplex, and they'll start when they manifest, they don't subside, because most of them will kind of um, remit on their own, right, with our supportive treatment. But sometimes they don't remit; they are there for even more than 1 month. So by the time you have somebody having episymplex infection that is not like outbreak, so it is there and it's not resolving and coming back. No, it is there for entire 1 month. There's a problem. So that's more like one of the manifestation of AIDS defining illness. So in that kind of person, you need to get the viral load, you need to get your CD4 count, place the person on heart, then now look towards controlling the infection. Because if you keep giving that person the acyclovir or valcyclovir, it will not work. So persistent ulcers, will be resistant to antiviral therapy, right? So you need to, assess the person for a background HIV infection and treat it accordingly. So don't forget the first presentation, the second presentation, supportive treatment, right? If the person is immunocompromised, make sure you are giving your antiviral, your valve within 72 hours, right? If the person is having recurrent, you can give supportive, you can give your valve, just to limit viral shedding, and promote faster healing, right? Because they will go on their own, but to promote the faster healing so that it limits the symptoms, the pain, and the likes, right? If the person is having frequent outbreaks, more than 6 times in a year, the person is having a lesion now, it will go again, come back again, go, come back, go, more than 6 times in a year. That's severely frequent outbreaks, right? So you need to place that person on the valve prophylaxis daily, like that, and then for the HIV one, you have to treat your HIV. So moving on to the varicella zoster virus, we have talked about these two. The varicella is just primary infection. The zoster is a secondary infection. They are transmitted by respiratory droplet and by direct contact, right? Um, the incubation period is about 10 to 20 days. We don't really need that information, but what we need to know is that um, after 24 hours of the prodromal symptoms, the eruption appears, and this lasts until the lesions crossed and they resolve. So what are the prodromal symptoms we are talking about? The patient having a prodrome of malaria, fever, headache, myalgia, right? Just don't feel all right. Just have this fever, headache, myalgia, and after 24 hours, the rash begins. So um, there's going to be like an evolutionary growth of the rash. So they start from macus to papules to vesicles to blisters, and they now finally crossed, right? But most of the time, you might catch them within this vesicular stage, which is going to be pyretic, right? Pyretic vesicles, that's what you see. And it moves out in a centrifugal pattern from the trunk to the head, to the face, the scalp, to the extremities, right? And at any given time, you will always see the rash at all stage. So you see some macles, some papules, see some vesicles, see some blisters. So by the time you are seeing that being described, think about chickenpox. And we have talked about the complication, pneumonia and encephalitis, right? Pneumonia, encephalitis. So, very, very important we remember that. So this might be the reason why you are doing um, your CSF analysis or you are doing your bronchoalveolar lavage. And we have talked about what you give this individual. You have to give them intravenous what? A cyclovir. Zoster. So this guy varicella can hide in the ganglion, the dorsal root ganglion, or the trigeminal ganglion, or the geniculate ganglion, any one of them, and it can reactivate, right? And when it's reactivating, it comes as the epizoster or the shingles. It comes as the epizoster or the shingles. It comes as the epizoster or the shingles, and depending on the specific nerve, that's going to affect whichever area is going to show up. So most of the time, they follow a particular dermatome. They can follow the thoracic dermatome, which is just like one segment of the thoracic region having these vesicles with erythematous base. You can see this erythematous base. I can see the tiny, tiny vesicles. That's classic for zoster. So before this rash appears, the individual will have started complaining of pain, tingling sensation, burning sensation within that area. So you get a question stem, somebody, and they are describing somebody having initial pain that is burning in sensation, that's tingling, and subsequently rash develops, vesicular rash, vesiculobullous rash. That is zoster they are describing. Having a dermatomal distribution. So the initial pain that they initially have before the rash develop is what we call acute epitic neuralgia, and it usually lasts for 30 days. So by the time you have that pain lasting for more than 30 days to 4 months, to up to 4 months, that is subacute epitic neuralgia. If the pain is now persisting for more than 4 months, that is post-epitic neuralgia. Uh, so I have talked about the way the rash is, and sometimes you can have this rash crossing the other adjacent dermatome. In that situation, once you see that presentation, think about disseminated epizoster, and it's very common in individuals who are immunocompromised. Or you see an individual having one lesion here, and the person is not having these lesions in another part of the body, which is not actually like adjacent, maybe somewhere up here, right? And it's more than 20. That also qualifies for disseminated immunosuppressed state. So don't forget the distribution of the acute epitic neuralgia, in which the pain will persist for the onset to less than 30 days. Don't forget. Then for subacute, they have the presentation for between 30 days to less than 4 months. And for the post-epitic neuralgia, just like I've said, for the post-epitic neuralgia, they have the pain persisting greater than 4 months for the onset of the rash. So we have to look at the complications of zoster infection. We have to essentially know three. We have talked about the first one, which is a post-epitic neuralgia, having pain persisting greater than 4 months from the rash onset. That is post-epitic neuralgia, and you have to treat that. You give them tricyclic antidepressant like amitriptyline. You can give them your TCAs, right? We are still going to look at that. We have it down. The more I say it, the better it sticks. Give them your TCAs. You can give them the gabapentin, or the pregabalin. If you don't have this, you can use depending on what is in question, you can use your capsaicin. You can use your capsaicin. Everything works, right? That's the treatment for the post-epitic neuralgia, for the Ramsay Hunt. So that means that the initial infection is affecting the geniculate ganglion. So when you have reactivation from the geniculate ganglion, so that is going to cause epizostal urticus or the Ramsay Hunt syndrome. And I want you guys to look for some constellation of signs and symptoms. And the first one is affectation of the hair, because the geniculate ganglion is related to the facial nerve, right? It helps to convey some of the sensory, the spatial sensory nerves, for the facial nerve, particularly the ones coming from the chorda tympani. We don't need to go into the anatomy. Just know that the geniculate ganglion is related to the facial nerve. And one of the nerves that is closely related to the facial nerve is the cranial nerve 8. It runs with the facial nerve. So when there's reactivation from this geniculate ganglion, it can easily affect the facial nerve. right? So, number one, you are going to see that this individual, from the word horticus, there's going to be vesicular lesions within the peni and the air canal. Number one, there's going to be affectation of the facial nerve, which is going to lead to like a lower motor neuron lesion. So there's going to be facial nerve paralysis, ipsilateral facial nerve paralysis, mouth deviation to the unaffected side. There's going to be loss of nasolabial folds at that part. You cannot open that particular eye, right? There's lots of wrinkle of that particular side. All those features suggestive of facial nerve palsy. Then the last one is um, feature suggestive of repetition of the cranial nerve 8. If the person is going to be having problems with balance, vertigo, and of course sensorineural deafness. So you have a patient that initially has this burning pain and the likes in a particular dermatome, and maybe subsequently develops, you know, uh, no, not that. Like, you have a patient initially having like vesicular lesions, right, in the body. Then after the resolution, then after some like months, the person start developing features of the Ramsey Hunt. So you think about episostyle oticus. So the hair pain, the vesicles within the hair canal, the facial nerve paralysis, and the vestibular cochlear nerve involvement. So the third is the episostyle ophthalmicus. So, and this is talking about reactivation of the 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 virus within the ophthalmic branch of the trigeminal nerve, right? So that means it's going to affect the upper eyelids, it's going to affect the upper part of the face, right? And from there, it can easily lead to infection affecting the eye. It is a medical emergency. You need to treat as soon as possible, give your a cyclovir, to to treat that infection as soon as possible, because it can, affect the eye. It can lead to conjunctivitis, it can lead to uveitis, it can lead to keratitis. It can even lead to, you know, elevation of the intraocular pressure, right? So, which could lead to blindness. So because of that, you need to give your antiviral agent as soon as possible to limit the chance of blindness. And there's also what you call the Hutchinson sign, in which you have, affectation of the nasociliary branch of the trigeminal nerve too, and you see the vesicle depositing within the tip of the nose. So that's also closely related to episostyle ophthalmicus. So one thing I must mention is that older people, they have a very high risk of developing post-epileptic neuralgia. In fact, that's one of the commonest, that's like the commonest risk factor for post-epileptic neuralgia. Never forget that. You know, Never forget that. So, and that is when the pain passes for more than 4 months at the infection site. So you have to read the question well and look at the duration to know what you are dealing with. If it's more than 4 months, after the onset of the rash, that is a case of post-epileptic neuralgia, and you can give any of this, your TCA, your gabapentin, or your capsaicin. How do you make diagnosis? You already know that most of them clinical from your exam finding, but you can do your PCR analysis and your viral culture, right? Varicella is usually self-limited in healthy children, right? So most of the time you don't need to do anything, you know. But in people that are immunosuppressed, they are high risk for developing varicella-induced pneumonia or encephalitis. But you have a live attenuated vaccine that should be given to children in 2 doses. Please, we should not forget this. I'm still going to show us the algorithm. We are still going to have a thorough look at the algorithm, but we should not forget this. You give it in 2 doses. So people that are immune to varicella, people that have received these 2 doses between the age of 1 and the second one at 4, uh, and people that have had a previous infection that they've recovered. So those are the two situations of people that are immune to varicella. Um, although it's not as if they are totally immune, they can still get infection, but the chance is very low, right? You also give it to adults more than 60 years, just like we have said. Give it to adults more than 60 years. People that are HIV positive, having a CD4 count more than 200. Don't forget, the varicella vaccine is what? Is a live attenuated vaccine. So you don't give it to individuals with CD4 count less than 200. Don't ever make that mistake in the exam hall. You don't give live attenuated vaccine like yellow fever, like MMR, like um, varicella to an individual with CD4 count less than 200 or individuals that are pregnant. Don't make that mistake, please. So those are the three categories: ages 1 to 4, adult more than 60, HIV people greater than, with CD4 count greater than 200. Very important stuff. We have talked about um, how you treat adults. So you can just give them your acyclovir to treat the symptoms and prevent the complications, right? That's just what you do. So somebody present you with um, the classic vesicle, just give your acyclovir to limit the symptoms and prevent complications. You know, um, then give your pain control because they are very painful by giving your NSAID, for the acute and the subacute epileptic neuralgia. And if the individual is now having the post-epileptic neuralgia, so in that kind of agent, you need to give them much more stronger stuff like your gabapentin, your pregabalin, and your TCA. But if it's just acute or subacute epileptic neuralgia, just give them NSAID. So don't forget, Zostar, just give them your acyclovir, treat it, and limit complications. Acyclovir works for them, systemic acyclovir. Uh, to manage some of the symptoms, you can use NSAID if it's acute or subacute epileptic neuralgia. If it's post-epileptic, give them the neuropathic agent. Very, very important stuff. Very, very important stuff. PEP can be needed in an individual that gets exposed to a child or anybody with chickenpox. So if somebody get exposed to anybody with chickenpox, you might need to give PEP, right? In the US, but in the US, it's not very common because everybody's kind of vaccinated. Or maybe a child will have had varicella in the past and they will have been immune, just like I've mentioned. But if needed, you have to segregate them into: are you immunocompromised or are you immunosuppressed? That's the first thing. So let's look at the algorithm I have here so that I will not just be saying it blindly. So you get a question that somebody get exposed to varicella, and the next thing they will ask you is just to decide what you are going to do. So ask yourself from the question stem, can you identify if this individual is immune to varicella? Because if the individual is immune to varicella, you don't need to do anything, just observe. And how do you know? Has the person, been infected with varicella before? If they said yes in the question, just observe. Or has this child or has the individual received the 2 doses of varicella when the person was a child between age 1 and 4? If the person has received 2 doses, observe. If the person only received one, please, that person is not immune. So you have to continue. Then you now ask after that, is this person immunocompetent or the person is immunosuppressed? If the person is immunocompetent, then your PEP that you are going to be giving will be varicella vaccine. But you make sure that you are giving it within 5 days of exposure, right? If it's within 5 days of if it's beyond 5 days of exposure, you can recommend vaccination, but the vaccination you are recommending is no longer for PEP. You have to define the terms. It's no longer to protect that person from developing infection at that acute setting. The person can still develop at the acute setting. So it's not for post-exposure, it's just for future, right? So you can only use it for post-exposure to prevent that current infection from developing, right? By giving it within 5 days of exposure. Very important stuff in an individual that is immunocompetent. But if the person is not immune to varicella and the person is immunocompromised, or the person is pregnant, or the person is a newborn, you are not going to be giving varicella vaccine. You cannot give them varicella vaccine because you have said it, you don't give it to immunosuppressed people or pregnant people. So what you are going to give them instead is the varicella immunoglobulin. And you are going to make sure you are giving it within 10 days of exposure. Within 10 days of exposure. Now, what is the clause about the newborn? You typically give it to newborn that is exposed to maternal infection from five days prior to delivery to 2 days after delivery. So if you know that the mother has varicella infection, you know, make sure you are giving that child the the vaccine within 5 days before delivery or 2 days after delivery, because within this time, that's when the child has a very high chance of contracting it from the mother, particularly when delivery is about to happen. So that's why you give it within that time. The last thing I'm going to mention is that if a child is uh less than 1 year, right, but the child is not a newborn but less than 1 year, and the person get exposed to an individual with varicella, you don't usually give them anything because they have a very low chance of developing varicella infection in that age, less than 1 year, right? Um, so yeah, that is that. Um, okay, is there anything I'm missing out? Yeah, so that's where you look at the algorithm. Um, okay. So we have talked about that. So we already know the complication, the ophthalmic cause, give your acyclovir, your Ramsey-Hunt syndrome, as well as, yeah, varicella, your congenital varicella syndrome. And this is, um, uh, a congenital infection that happens within usually the first and second trimester from varicella infection. So the mother can transmit the varicella to the child, particularly within the first and the second trimester, and the child can develop these congenital anomalies. You are looking out for skin problems, limb problems, eye problems, and the brain problems. So um, they usually have hypertrophy scars. So this is the reason why you might not need an acronym here is that it's very, very, quite different from most of the other congenital infection that you are just, having maybe microcephaly, intracranial calcification. So you already know the one that has intracranial calcification, the one with, you know, basal ganglia calcification or subcortical calcification, the one with periventricular calcification. Everything is just classic, but this one is quite separated from them. They have skin problems, cicatrization, just see skin hypertrophy. They have limb problems, limb hypoplasia. They have cataract in their eyes, and they have cortical atrophy. So once you see this, you think about congenital varicella syndrome. So moving on to molluscum contagiosum. So this is a pox virus. So that's the largest DNA virus. You know, that's very common in young children and hate people. Yeah, very common in the young and the hate. So because it's sexually transmitted, you typically see the lesions within the genital areas in adults. And in young children, because they typically get it from use of fomites, towels, clothes, and the like. So you see it in their body, like the trunk, the face. By the time they are rubbing the towel on the face, the trunk, when they wear the clothes or they apply the towel, then their extremities, right? So very common through skin to skin contact with an affected person, maybe you use sex, sport, or sharing formats like clothing and towels. What do you need to look out for in the question stem? Just look for the central umbilication. So you just see like all these papules with a central indentation or umbilication. That is molluscum for you. So the question is going to be describing it as presence of flesh-colored dome shape papules. Flesh color, you can see that it resembles this person's skin. They are dome shape with central umbilication. And you see them on the face, right? Depending on the age group, the extremities and the trunk. While in adults, because they are much more shared with sexual transmission, so you find them within the genital area and the perineal regions. They typically spare the palms and the sole. We cannot start talking about the lesions that affect the palm and sole. We know all of them, like syphilis, hand, foot, and mouth, from the Coxsackie, erythema multiforme, you know, um, which ones again? Rickettsia. You guys can tell me more. So the lesions are usually asymptomatic unless when they become irritated or inflamed. So most of that they are painless. So don't forget Kaposi sarcoma, painless, not pruritic, um, violaceous, purplish, pinkish plaques and nodules with lymphocytic infiltrate and spindle cells with somebody with background immunosuppression, Kaposi sarcoma. So just like here too, they are asymptomatic, not unless they are inflamed or irritated. So the diagnosis is clinical just from your observation and from the history. Um, your most accurate test to confirm is to do your biopsy, and do your histology, and you use your right stain on gypsum stain. These stains are used for malaria, and you are going to see large inclusions or majorly your molluscum body. So I have a picture, that depicts the molluscum body. They are just like indentation in the epidermis, right? Cup shape indentation in the epidermis. So this is what you are going to have. You know, uh, can I zoom this? Oh no. Okay, let me see. Okay, yeah. So you can see that the cup shape indentation of the epidermis here, containing eosinophilic. You can see that it looks a little bit like red, quite different from this. Eosinophilic cytoplasmic inclusions. Once you see this cup shape indentation, think about molluscum contact. Of course, the history is going to put it out fast, so we don't need to worry ourselves about molluscum at all. How do you treat? First, before you treat, there's a key fact. You need to, once you see a giant molluscum that is big or widespread, think about a background immunosuppression. That person has HIV, or the person has anything that's causing a drop in the cellular immunity, right? So don't forget, sexually transmitted, very common in people that are immunosuppressed, like HIV, or other things that brings about immunosuppression. So how do you treat? In children, you don't do anything. It resolves on its own, usually. Uh, most of the time you just leave it resolve on its own in children, but you can, for adults, you can do your local disruption. So, and the first line is doing your cryotherapy by applying liquid nitrogen. So you can do your cryotherapy, right? You can do laser ablation, right? You can do curating. So just do your curating, just scrape it off, do your cryosurgery or laser ablation. And you can also apply vesicants, agents that cause blisters, just blister out that lesion. An example of that is cantharidin. So cantharidin can be used. So just think about cryotherapy, liquid nitrogen. You scrape it off, which is your curettage, right? And you use your laser to ablate it. Then moving on to the warts. So the warts are caused by the human papillomavirus. They affect the skin, the mucous membrane, and the other epithelia usually. The skin and the mucous membrane usually. You know, they can affect the other epithelia, and lead to malignancy. Um, that's that. And usually they are benign because what we are looking at here is warts. So most of the time the warts, they are usually benign. And some of the subtype of the human papillomavirus can cause, malignancies, particularly the serotype 16 and 18. They are notorious. While the serotype 6 and 11, they are very much more implicated in causing the warts, which is benign, which are benign growth and they are not malignant growth. So the spread is usually by direct contact. So that's why HPV can be transmitted by sexual, transmission. So most commonly you see the wart in the hands, right? You can also see it in the genital areas, you can see it in the vulva, the penis, the perianal region. So depending on the mechanism of transmission. So, and that's the base for their classification: the planar warts in the foot, the flat warts, the genital warts, and depending on the location. So, the most of them you see it in the hands. You can see the classic genital warts, which you call condyloma acuminatum, caused by the serotype 6 and 11, just like we have. And you see them, forming this wart within the genital area. So you see what the appearance of the wart is going to be skin color too, just like molluscum, but they are going to have this waxy presentation, like having a shape of a cauliflower, you know, plaques and purple. Once you see something that looks like this cauliflower deposit, cauliflower solid elevations or plaques, think about what. And sometimes the mother can transmit the HPV virus, to the infant during delivery, because during delivery you can have the infant aspirating the virus, during delivery. And when the infant aspirates it, the infant can develop respiratory papillomatosis. And I have some short notes here about respiratory papillomatosis, because it's more like a benign growth, right? It's a benign tumor that is much more caused by the serotype 6 and 11. It is a benign tumor of the laryngeal stratified squamous epithelium, right? Caused by the human herpes virus 6 and 11. So it's very important for us to remember this. It can come out in your exam, and it occurs during vertical transmission, from when the baby is getting delivered. So because that's when the baby, have the opportunity to aspirate the vaginal secretion. So the clinical features usually, variable. They can have the what or the papilloma, affecting the upper airway, which is the larynx, the vocal cord. So they can have hoarseness of voice, they can have dysphonia from there, they can have stridor, noisy breathing, right? Can have cough, difficulty in breathing if it's large enough to occlude the airway totally. And by the time you do your laryngoscopy, so the best way to investigate is to do your laryngoscopy, and what you are going to be seeing is raspberry-like swelling. So I have an image to show us what it looks like. For some of us that are familiar with some of those fruits, this looks like clusters of raspberry, and this is like the vocal cords, with the ingrowth here. 6 and 11, don't forget. And sometimes it can transform into the squamous squamous cancer, and sometimes it might be big enough to occlude the airway, leading to respiratory, failure. So usually they present with hoarseness of voice, stridor, dysphonia, difficulty in breathing, weak cry. So you can use your history, to make the diagnosis of the what most of the time. Sometimes to isolate the what from the surrounding skin, and to distinguish it, you can stain it with the acetic acid. So it's going to turn white, you know, particularly to visualize the mucosal lesions. So they are going to turn white by the time you apply acetic acid. The most accurate test is to do your PCR of the lesion, you know, sequencing for your human papilloma virus. Yeah. So how do you treat? How do you treat? So most of the time, what you do is just like, like a local removal, right? You can do your cryotherapy with your liquid nitrogen. You can excise, surgically. You can do your laser therapy just like you do for mollusco. Cryotherapy, laser, you know. But here you can also do surgical excision, because some of them can be very big, right? For genital one, you can apply some chemicals like podophyllene. But podophyllene and imiquimod. So imiquimod is more like an immunomodulatory drug that activates the toll-like receptor 7. So activating the macrophages to take off that microbe, to take up the infection and resolve the lesions. So, but imiquimod and podophyllene, both of them, they are teratogenic. So you avoid it in people that are pregnant, right? You can only use TCA in the trichloroacetic acid, right? So there's a way you can remember this, because you said it that acetic acid is what you use to stain the mucosal lesions so that they can be conspicuous, because they will appear whitish. Sorry, excuse me. And you can use trichloroacetic acid to treat them as well, particularly the genital ones. And if an individual is pregnant, you avoid the other ones, which is podophyllene and imiquimod. Or if the person is not pregnant, you can use any of the three: podophyllene, trichloroacetic acid, imiquimod would be used. So because this is caused by HPV virus, it can cause cervical cancer, it can cause cancer of the head and neck. So if you are dealing with genital warts, you know that there's a high risk of that genital wart progressing into cervical cancer. So you need to do your pap smear and the, you know monitoring for potential malignancy. Then, of course, the person is not vaccinated, the person is more than 21 years, vaccinate that person and encourage use of barrier method of contraception. So don't forget the mechanism of treating because that's important. They can ask you. For the skinny one, you can do your normal, just like you do for molluscum, do your surgical excision, and just like what you do for molluscum, do your laser therapy or do your cryotherapy, and for genital one, you can do that or you can apply some chemicals like podophyllene, you can apply trichloroacetic acid and imiquimab. But if the patient is pregnant, avoid imiquimab and the podophyllene. So routine surveillance for cervical cancer, encourage barrier method and vaccination. So come to the end of the viral agent.